Look good? All right. Awesome. Well, as always, I'm so excited. Sorry about that. I am so excited to be here with you guys and talk about issues related to equity. And what we're going to talk about today is really a program or sort of a service that can potentially bridge the gap and promote equity, particularly for our marginalized and minoritized population. So we're going to talk about cultural brokering today. So just as a review, when we think about health inequity, really we think about sort of this process that perpetuates persistent health disparities and leads to health inequity. So we start sort of broadly with structural inequities, and that can be anything from historical and contemporary racism to racial inequality to their impact on social determinants of health or social determinants of poor health, if you want to think about it that way, which then leads to health inequities and those persistent health disparities. So if you think of sort of this like a card game, basically your structural inequities are sort of like the rules of the game, if you will. The social determinants of health are the cards that you're dealt by the dealer. And the health inequities and the health disparities are basically all the wins, losses, and sort of everything in between. Now, with any card game, there's advantages and disadvantages. Sometimes the dealer goes rogue and potentially causes you to not have maybe a good hand or so. But basically, when we're thinking about those structural inequities, they basically have unbalanced card decks that, if you will, that get disseminated, right? And so some people have advantages, some people have privileges, and some people have disadvantages and do not share or participate in those same privileges. And so that's what really leads to those social determinants of poor health and then those resulting health disparities. So when you think about social determinants of health, or again, social determinants of poor health, we're really looking at all of the different factors. And I've given presentations for this ECHO, which I love. And so you see this particular graph a lot in my presentations because I just really like it. Basically, we're talking about, how do we create healthy individuals, or how do we foster healthy individuals? Well, historically in traditional medicine and traditional behavioral health, we really thought about treating the individual when they come in for the issue that they're presenting with. We treat that issue, we treat that person, and then we kind of send them on their way. And what we now realize, or sort of now are really espousing, is that we really can't help foster healthy individuals if we don't have healthy communities, healthy environments, and healthy societies. And part of that in creating those healthy communities, environments, and societies are ensuring that people have access to the things on the left and the right of basically that central figure, that people have access to preventive services, mental health services, culturally linguistically appropriate services, and so on. You'll also notice toward the right, you do see, particularly some emphasis on discrimination and minority stressors. So again, really wanting to think about racial inequality, racial and ethnic health disparities as well when we're thinking about these issues. So I'm just going to take the Hispanic and Latino population as an example of sort of gaps in treatment when it comes to behavioral health. So what this graph basically looks at 2018 data, but basically looks at Hispanics who have treatment need. So you'll see the darker basic shades of the bars are people who are actually in treatment and have treatment need, but then the total bar represents treatment need. So basically you're looking at a large percentage of the Hispanic and Latino population who are not engaged in treatment despite significant treatment need. And that is across sort of issues or concerns when it comes to behavioral health. So we're looking at substance use, any mental illness, serious mental illness, co-occurring mental illness, and then major depressive disorder. So really across the board, we're sort of seeing the same issue, which is despite treatment need, Hispanic and Latinos are not engaged in treatment for various reasons, which we'll just talk about next. There are a variety of barriers to mental and behavioral health engagement for Hispanic and Latino populations, as well as other historically marginalized and minoritized populations. However, I want to focus on these four because they sort of really lead to cultural brokering, which we're going to talk about in a second. First and foremost, there are those structural barriers to services. So those are going to be just your structural issues that potentially make it more challenging or more difficult for someone to engage in behavioral health and mental health services consistently. So not only makes it difficult for them to get in the door to begin with, to just make that first appointment, but then also makes it difficult for them to potentially be retained in treatment as well. So that could be things such as concrete barriers, such as transportation issues, long wait lists, times of appointments or times of services that don't coincide with someone's work schedule or availability. So those are sort of structural barriers, including not being able to access services because of insurance coverage or lack thereof insurance coverage. When it comes to mental and behavioral health in the Hispanic and Latino population, as well as other racial and ethnic diverse groups, we also have cultural stigma around mental and behavioral health. And that is something that definitely, I think, from a national standpoint, in terms of just overall mental health stigma, we're making some headway in terms of normalizing and really talking about mental and behavioral health openly, and doing a lot of that in the media as well. But when it comes to diverse cultural groups, there are, other cultural kind of barriers as well in terms of that stigma that we do need to address. And that, again, we're making some headway, but we have a long way to go in that regard. When it comes to services, there's also barriers when it comes to the cultural and linguistic competence of services. So while when a family gets in the door of services, it doesn't necessarily mean that those services are appropriate or meet their needs, and particularly from the cultural and linguistic side of things. So one of the things is ensuring that services are culturally and linguistically appropriate. That means that services are not only provided in using interpreters for language access, but then also ensuring that services attend to and address issues of culture in their treatment provision and their service delivery. So that is something that we hear a lot from families, actually. I work a lot closely with the Hispanic and Latino population, and there are very few bilingual providers, so that in and of itself is a barrier. But even among other providers that do provide interpretation services, there is feedback that sometimes the services don't meet their cultural needs or don't seem to attend to cultural factors. And so that's something we really want to pay attention to. And then, as I mentioned, just making sure that we're ensuring language access and accessibility, providing interpreter services when needed, using translation services for behavioral health and mental health documents as well, when available as well. So those are just some of the barriers. So how do we potentially address some of these barriers, or how do we sort of bridge that gap that those barriers create? Well, cultural brokering is actually a really good method, a really good practice that can potentially bridge that gap and can also potentially address those barriers. So what is cultural brokering? It's basically bridging, linking, or mediating between groups or persons of different cultural backgrounds for the purposes of reducing conflict or producing change. We really think about cultural brokering, though, in the healthcare setting as basically linking between a cultural or community group and the healthcare system. And within the healthcare system, we are including mental and behavioral health as well. A cultural broker acts as a go-between who advocates on behalf of another individual or group. So we'll talk a little bit more specifically about who is a cultural broker and what roles does a cultural broker serve next. But first, why is it important, or why do we even think about using cultural brokering? Why is this a strategy or a service that might be useful in healthcare settings? Well, first and foremost, we do know that with the projected demographic trends in the United States, we are going to see an increasing diversity within our United States population. In terms of racial and ethnic groups, and then in terms of individuals who are just from a variety of diverse backgrounds. So just ensuring that we are thinking about how are we going to address those trends or those changes in demographics. That there is also an emphasis on cultural and linguistic competence in healthcare organizations. So for those of you who are aware, we do have the class standards, the cultural and linguistic appropriate standards for healthcare. That is sort of a federal guideline. If you're an entity that receives federal funding, they do want you to be utilizing or at least working within the class standards as a guideline. And so that emphasis is also something that may promote use of cultural brokering as a means of saying you're sort of working within that standard. That there are current disparities in healthcare access, treatment, and outcomes. Those existing disparities were very much highlighted or exacerbated as well during the COVID-19 pandemic, obviously, which we are still currently in. And so those disparities being highlighted, I think, brought a lot more attention into how do we address these gaps in a way that maybe is going to be sustainable long term. Obviously, emphasis on promoting behavioral health equity and health equity in general. We know that there's diverse belief systems related to health, healing, and wellness in the healthcare system. So really having cultural brokers that maybe potentially are more familiar with those diverse belief systems and can, again, act as sort of a go-between to help foster understanding and respect and mutual empowerment, frankly. We know there's cultural variations in the perception of illness, disease, and their causes, including mental health conditions as well there. And we know that there's cultural influences on help-seeking behaviors and attitudes towards healthcare providers. Again, something that cultural brokers can help healthcare organizations understand and also sort of work within that, with that knowledge to help promote services and service delivery that meets the needs of those diverse populations. And we also know that we should respect and there is utility in honoring and respecting Indigenous and traditional healing practices among many cultural groups. Something that maybe we're not in the healthcare system, we may not completely be familiar with. And so a cultural broker can act as someone who provides not only that link in terms of helping facilitate that understanding and the knowledge of those practices, but then can sort of, again, help bridge any gap or linkage between the population and the healthcare system with regards to those issues. So who are cultural brokers? Really, at the end of the day, frankly, anyone can be a cultural broker. It's basically who works with the patient or family. So it can be a community member, it can be a lay health worker or a community health worker, it can be an interpreter, it can be a provider themselves or some member of the clinical staff, a therapist or social worker when we're talking about mental health services. It can also be a peer supporter or someone who's a offers peer support, and then a peer mentor. So really, who are the individuals who work with the patient or family? Any of those individuals can be a cultural broker. Their role in and of itself does not make them a cultural broker. It's if they serve in one of these roles, but then also take on some of the functions of a cultural broker that allows them to sort of serve in this capacity. And I'll sort of go into those roles now. So what are the roles that a cultural broker fills? They can be a liaison. So again, they serve as a liaison between the cultural group or community group of interest and the healthcare system. Again, we're sort of using cultural broker in the context of this healthcare system. So they sort of serve as a liaison in linking those two groups. They can also serve as a guide. So cultural brokers can really serve as a guide for healthcare organizations or healthcare entities to really try and improve the cultural and linguistic competence of their organization or entity. So that can mean that they help establish recommendations or guidelines in terms of working with these various community or cultural groups. They can offer insight into what is appropriate health literacy material for this particular population. So they can guide some services or guide recommendations to help healthcare organizations or healthcare entities provide more culturally and linguistic appropriate services. They can also be an advocate. So they can advocate on behalf of the community or cultural group or the individual or family that they're working with in terms of their interaction and in terms of their interactions or in terms of their experiences within the healthcare system. So serve as an advocate, ensuring that their needs, their desires are also well communicated to providers and well communicated within the healthcare organization. They can also serve as a mediator. We do know that historically and contemporarily marginalized and minoritized populations do have a history of mistrust of the healthcare system and of medicine in general. And so a cultural broker can sort of serve as a mediator in terms of fostering some of that trust, fostering a good working relationship with the healthcare system for some of these populations that may be a little bit more hesitant or resistant to engage. And cultural brokers can also serve as a catalyst for change. Again, they can inspire change on the healthcare system level or within the healthcare entity to, again, improve services, improve service delivery, but they can also catalyze change for the community and cultural groups that they work with in terms of health behavior, in terms of health engaging in those health recommendations as well. So they can be a catalyst for change on both sides of the coin. So what are the benefits of cultural brokering? To the patient, it's engagement. It fosters engagement within the healthcare system. You're more likely to also keep individuals within the healthcare system, keep them in treatment. So it fosters retention. It also promotes earlier intervention for populations that historically or typically enter the healthcare system later than we would want them to, maybe with more increased morbidity or increased severity in some of their symptoms. Fosters comfort and trust, again, particularly important for our populations who historically have felt victimized by the healthcare system. And it also offers an opportunity for community impact for the patient. For the provider in the system, it makes their prevention and health promotion services more targeted, likely to be more of a fit for some of the populations that they're interested in serving. It improves service delivery and improves the quality of care that they provide for these individuals and vulnerable populations. It can show reduction in costs and healthcare costs. So there's been some research that looks at the financial benefit of using systems like cultural brokering. And you do see some reduced healthcare costs, for example, like decreased emergency department utilization, things like that. And it also fosters more connection to the community. If you have a cultural broker who sort of serves within an healthcare organization, they're more likely to be connected or have a better working relationship with the community or cultural group of interest. So those are sort of the benefits also to the provider of the system. Okay, and how do cultural brokers really sort of, think about addressing barriers? Well, we think about point of contact barriers, and those are sort of we talked about cultural brokering as sort of addressing a lot of these factors in terms of barriers, especially like the stigma, the cultural and linguistic competence, and the language access. But then we still have these point of contact barriers, sometimes that prevent individuals from just engaging initially, just getting that initial appointment for behavioral and mental health care. And we know that even just getting that one first appointment and completing that first appointment is actually really critical. And we have a lot of lack of completion for that first appointment for a lot of our vulnerable populations. So reasons for that is that sometimes we have these point of contact barriers. It's hard to initiate contact or hard to initiate engagement. There's insurance coverage that prevents from that first appointment from being scheduled or completed. There are those transportation concerns. There are issues with language accessibility and availability of interpretation services, particularly for our limited English speaking populations. And so now I'm going to turn and talk to you a little bit about two different types of individuals or services that act as a cultural broker in their role. So prior to my stop at Cleveland Clinic, I actually worked at the Ohio Department of Mental Health and Addiction Services. And one of the things that I was able to do while I was there was establish this idea of this Ohio Latino Community Mental Health Navigator. It was a partnership between the Ohio Commission on Hispanic and Latino Affairs and the Ohio Department of Mental Health and Addiction Services. And basically the idea was, we know that these point of contact barriers exist. We know that if we can find some way to address those barriers and reduce those point of contact barriers, then we're more likely to get our Hispanic and Latino population to engage in behavioral health treatment. So what we did was we piloted a bilingual community mental health navigator program serving communities in central Ohio. And the entity there was Our Lady of Guadalupe Center in Columbus. And then Southwest Ohio, the entity there was Su Casa. They are two basically social service agencies that provide services specifically to Hispanic and Latinx populations. And they basically served as the pilot programs. So using some funding, again, from the Ohio Department of Mental Health and Addiction Services, they were able to employ a mental health navigator whose role was essentially to help connect individuals who had mental or behavioral health concerns with the appropriate mental health service or behavioral health agency where they could get services for them. And I'll sort of explain how that works in just a second. Because the pilot program was sort of replicated from an existing program here in actually Northeast Ohio in Lorain. So we had a group at El Centro here who's already doing a community mental health navigator program. And so they agreed to provide some technical assistance for these pilot programs so that we could launch them. The idea is if we could get a community mental health navigator program in primary regions within Ohio where there is a large Hispanic and Latino population, it would be a good service for the population and likely increase their engagement with behavioral health in these primary geographic regions. And so the expected product and outcomes for this pilot were to establish feasibility of having a mental health navigator program, and then the acceptability. Did this work for the community themselves? So basically, the Community Mental Health Navigator served as a bilingual central coordinating post. So essentially, they would locate resources and facilitate referrals. How this would work was basically a individual would call in to the call line, or they would walk into the agency. They would express need for or express concern for behavioral and mental health. The Community Mental Health Navigator sort of had a working knowledge of all of the different agencies within the area. They had knowledge of what insurance those agencies took, or whether they also offered a sliding fee scale if you did not have insurance. They had knowledge of whether or not these entities provided had bilingual providers, or if they provided services with with live interpreters or video interpreters or phone interpreters. They also knew like transportation issues in terms of how to get there. Were they on a bus line? Where did you need to drive? How far would that be from the individual's home? And basically, they would sort of know all of those things and then provide a recommendation for where they should get mental health and behavioral health services. They would also know wait list time. So they would get updates on, what the wait list is at this particular entity, and ensure that they could try and get someone in as quickly as possible at an agency or an entity that would provide the service that is necessary. So basically, the idea is that the Community Mental Health Navigator worked as a cultural broker in that sense, navigating between the mental health care system and the community of interest, and also would reduce those point of contact barriers, because now the individual or the family themselves aren't having to make multiple phone calls, potentially in a language that they're not proficient in, but would have all of that information and sort of give them a more specific referral. And for some of them, they would actually schedule that appointment for them. So all the family really had to do was show up for that appointment, and they would have a structured way of getting there. So the idea was that it would promote engagement in behavioral health care and provide client advocacy, because again, some of the concerns that we had heard were that families were being directed to places without really any knowing what kind of entity it was or what kind of services they provided, and feeling that it wasn't a good fit, sort of a cold call referral. And that wasn't working for the community. They wanted some, not guarantee, but they wanted some more familiarity, that we could say, like, this is an entity that we know, they provide this kind of service, this kind of quality of care, and the community really needed that to facilitate that trust in the system. So in terms of the pilot program, in terms of outcomes, we did develop a network of culturally sensitive mental health care resources. We did refer to internal and external programs that provided mental health care to families experiencing trauma. And they worked with external agencies to develop a continuum of care utilizing community mental health programs. So for example, if a patient did not show up to their scheduled first appointment, the Community Mental Health Navigator would get back in touch with the family and say, okay, hey, what was, what prevented you from getting to that appointment? What can we do to make sure that we, get you involved, or get you seen by a behavioral health care provider? And I think one of the interesting side notes that we didn't really put on here, but was that a lot of the agencies that the mental health navigator worked with, they also started to think about their own services and how they could provide and improve the cultural linguistic competence of their own services. So that's also a byproduct of the program. And then the outcomes is they coordinated and tracked care for Latinos or Spanish speakers. They tracked and monitored resource gaps for Hispanic and Spanish speakers. And then they empowered and educated clients about mental health. So even if it was just a community mental health navigator talking to them about some of these mental health concerns and helping them understand these concerns, that in of itself was an intervention that was helpful for a lot of our families, because again, the mental health navigator was already embedded within this trusted organization, the social service agency that families were familiar with. So they inherently had trust on behalf of the communities. And then meaning that when the communities came to them and that mental health navigator was talking to them about mental health and behavioral health services, there was some added credibility there, that allowed some of our families who were resistant to talking about mental and behavioral health to really become more open to the idea of seeing a counselor or a therapist, or being seen for some of these concerns. So this just sort of explains a little bit about the process. Is, behavioral health needs are identified. We have a community mental health navigator. We have cultural brokering going on, and that benefits the behavioral health system. However, We still have gaps within the behavioral health system. We still have lack of language access, lack of cultural proficiency in some of our mental health and behavioral health services, and still there's some lack of availability and accessibility. There were still wait times. There were still wait times that, for many of our families, they could not wait that long. So there were still some gaps. So we then think about how do we bring behavioral health services into the community as opposed to having individuals from the community go to behavioral health services, try and bring something a little bit closer to home. So we have these community mental health workers. We call them promotores de salud mental. So they're focusing on mental health and wellness. But they're basically health workers who work with the Hispanic and Latinx communities, and they leverage the effectiveness of community health workers in physical health and public health. So community health workers were first established for the purposes of like managing chronic disease in vulnerable populations, sort of taking a page from that and applying it now to mental and behavioral health. They address current deficits in the mental health and behavioral health workforce. We know, again, that the behavioral health workforce, there is a shortage, and we just don't have enough providers to meet the demand, particularly on the heels or in the midst of the COVID-19 pandemic. So we know that we need more creative and innovative ways to get behavioral health services into some of our communities. So basically, we employ members of the communities as they are members of their own communities, and they serve their communities by providing firsthand knowledge of community needs and resources. And they work and provide services in the community. They do receive specialized training in areas of service, so specifically in mental and behavioral health, but they provide, initial information, psychoeducation, prevention information regarding mental wellness. They're really trying to focus on prevention and health promotion and early identification. So they work towards preventing mental illness and promoting wellness through education, dissemination of information, and availability of resources, facilitating, again, that connection between the community and the behavioral healthcare system, and advocating on behalf of the community itself. So in terms of sort of recommendations moving forward, we do think that we need to invest in building additional frontline capacity for mental health and behavioral health. And that doesn't necessarily just mean counselors and therapists, but really looking at expanding the network of non-traditional mental health providers. Some of these programs can easily coordinate with health plans, county health plans, and county health improvement plans. Most county health plans or county health improvement plans have emphasis on mental health and addressing mental health disparities or behavioral health disparities. These are ways, cultural brokering, whether community mental health navigator, whether a promotora de salud, whether it's just, a therapist within an agency, advocating for use of cultural brokering can really coordinate, can really help excel some of the goals of some of these plans. And then we are trying to do more program implementation of some of these programs with ongoing process monitoring and improvement to enhance some of these services. And we do recommend, where possible, especially within counties that maybe have a variety of resources available, to try and help populations engage who traditionally are maybe a little bit less likely to engage in those services. How do you implement community mental health navigator programs? You can work on conducting an environmental scan where you get a scan of what are all the resources available in your area, coordinate with local mental health boards and behavioral health authorities, support sustainable lines of funding for these programs. Partner with existing CBOs or MCBOs, so community-based organizations or minority community-based organizations, and work on building capacity for these programs, supporting flexible lines of funding. Just to give a shout out to a colleague of mine, he's no longer there, but really a nice example of a promotora de salud model in some ways was the Cultural Ally program that was available. It is available through Stark County Mental Health Board. My friend and colleague, Isaac Baez, was very central in facilitating that, but that really functioned well in terms of helping connect vulnerable populations, Hispanic, Latino, as well as African American, and Hispanic and Latinx populations that did not speak necessarily Spanish, but spoke more indigenous languages as well, helping get them connected with mental health services. And so just another good example of some of the good work being done around the state. So I just wanted to kind of, throw out, again, just some recommendations around these programs and how they can potentially be useful in terms of enhancing treatment engagement and treatment retention for vulnerable populations. These are the references. The third one, the bullet, is a really great resource on cultural brokering if you're looking for more information. It's a little dated, but all of the information is still very relevant. So that's a great resource. And then here's my contact information, and that's it. So I will